evening. We're going to go ahead and get started with our fantastic speakers in just a couple of minutes. First, just a couple of housekeeping items. As we're a large group, you'll find your cameras and mics are automatically off, so please use the Q&A box for questions. And this recording, this webinar will be recorded, and we're going to put the recording on the Greener Practice website. The slides themselves won't be shared. Okay, so my name is Katrina Callan. I'm a GP registrar in Oxford, and I'll be your chair this evening. I've been involved with Greener Practice for the last 3 years or so. For anybody from the large Midlands cohort, I think we have here this evening, I'm a different Katrina from the Katrina Davis based in Midlands, another GP. So first of all, and before I pass over to Artie as our first speaker, just to give some background for anybody not familiar with Greener Practice before. So Greener Practice is a community of healthcare professionals working together to inspire sustainable primary care. Greener Practice includes professionals working in all different roles in general practice, engaging primary care for the health of people and planet. We run the UK's primary care sustainability network with over 30 local groups across the UK, comprising hundreds of clinicians. And at Greener Practice, we see the new joint BTS and ISIGN asthma guidelines as a huge opportunity to improve the health of both people and planet. And so we are sharing this update with you, focusing on the role of all of us working in general practice to put this evidence-based guideline into practice. And our speakers tonight are practicing GPs, Dr. Artie Bansal and Dr. Veena Agarwal, who have great knowledge of both asthma care and frontline general practice. And then we'll also have Deb Lees, a respiratory pharmacist, and Dr. LJ Smith, a respiratory consultant, joining us for Q&A. So I'm going to introduce Dr. Artie Bansal now. Artie is a GP in Sheffield and the clinical sustainability lead for Humber and North Yorkshire ICB. She founded the Greener Practice Network in 2017 to enable primary care to move towards environmentally sustainable healthcare. Artie has a background in medical education and has published award-winning research on person-centeredness, as well as contributing to Health Education England and RCGP's planetary health curriculum for GPs. She has a particular interest in how to implement good asthma care and has led the development of Greener Practice's high-quality and low-carbon asthma care quality improvement toolkit, of which more anon. So over to you, Artie. Thanks so much.
Thank you, Katrina. So I'm just going to share my slides, and Katrina, if you could tell me when you can see them. And start from the slideshow from the beginning. Fabulous. So welcome everyone, and thank you so much for coming out, as Katrina says, on a Wednesday evening. As Katrina mentioned, this webinar is very much aimed at people working in general practice who are interested in the practical aspects of how to improve asthma care in their practice. You want to understand what the new guidance means and how we can implement it. So I'm very much coming at this from a jobbing GP perspective, don't have any particular specialist respiratory knowledge, but I have been involved nationally with considering how we can implement better asthma care in general practice. And what I thought I would do is start with the context of asthma care in the UK and the reasons why it needs to improve, give you some of the background knowledge on the theory for the changes in the new asthma guidance, and then consider what that actually means for us in practice. And I like to start with key messages that I hope will come through in the presentation and that you will take away. So one of the key messages is that asthma is a common but long-term condition characterized by chronic airways inflammation. And it's this airways inflammation that drives those variable symptoms that we see, whether that be cough, wheeze, chest tightness, or shortness of breath. The second thing is that there is a lot of morbidity and mortality that is avoidable that we see from asthma in the UK, and this is preventable largely through better prescribing. So this is something that is within our gift to change. And in terms of changing it, there are two things that I think help us to think about how to consider it. The first one is, are people getting the right medicine? And the things that I'm going to talk about is seeing the inhaled corticosteroid as the treatment and the short-acting beta agonist as rescue, making sure that nobody is on just SABA alone, and then considering combination treatments to enable people to get the right treatment. And the second is the medicine getting to the right place? Are people on the most appropriate inhaler device for them? And as Katrina mentioned, we really feel like the new guidance could actually drive transformative improvements in asthma care. And it's worth just remembering what our aims should be for asthma management, because we're wanting to do two things. We're wanting to prevent symptoms and reduce risks. And if asthma is well controlled, which for the vast majority of patients we should be able to achieve good control, then what we mean by that is that people shouldn't be having any symptoms at all. So no daytime symptoms or very few daytime symptoms, definitely not needing your reliever inhaler more than twice a week, not having any symptoms that wake you up at night, and not having to restrict your activity and then not getting any exacerbations. But we also want to reduce risks. So we want to make sure that people don't have asthma attacks. Obviously, these asthma attacks can be dangerous. They can also mean that we have to give people high-dose oral steroid courses. And we know that even 4 or 5 oral steroid courses in a lifetime can increase people's risks of things like osteoporosis, cataract, and diabetes. And then, of course, if you've got asthma that has been uncontrolled and poorly treated for a long time, then that can cause chronic problems with lungs as well. So those should be our aims for asthma management. And I think sometimes people normalize having symptoms, both patients and healthcare professionals. So we need to make sure we're aiming high. And this slide actually quite shocked me when I first saw it. So this is a slide from Asthma and Lung UK's Breathing Unequal report, which they published in July 2023. And they did a survey to see what percentage of patients would describe their asthma as being poorly controlled, and actually asked them what kind of symptoms they were getting, how often they were getting these symptoms. And the purple bars show you how many, what percentage of patients had uncontrolled asthma. Now that means that there were far more people with uncontrolled asthma than well-controlled asthma. And actually this is also shown in many research studies which show up to 50% of asthma patients having uncontrolled asthma, by which we mean they're having frequent symptoms, or they're waking at night, or they're getting exacerbations. And of course, as with many long-term conditions, in asthma, there is also a health inequalities issue. So those in poorer households are more at risk of having uncontrolled asthma and less likely to have well-controlled asthma. And of course, if your asthma is uncontrolled, then occasionally it can lead to tragedy. And it's worth looking at how we're doing in the UK compared to our European counterparts. The situation isn't good. In the UK, we have some of the highest mortality rates from asthma in Europe. And this has been the case for many years, and it's not getting better. If anything, it's getting worse. So the last data that we have actually showed an increase, a significant increase in the asthma deaths that we've had in the UK. And back in 2014, the National Review of Asthma Deaths actually looked into this in detail and said that 2/3 of these asthma deaths were preventable. So why is asthma control poor? Now, obviously, there are wider determinants around here. There are things like smoking, air pollution, housing, which also have an impact on asthma control. But if we just look at treatment, then there's two main issues here. One is that people are not using the right medicine. And we know from studies that in the real world, there's very low adherence to preventer inhalers. So that's your inhaled corticosteroid inhaler. Studies sort of show us that adherence can be as low as 15% or maybe up to 54%, but it's definitely not high. And then the other problem is that people are over-reliant on their rescue inhalers. Now, I'm very specifically calling it rescue inhaler rather than reliever inhaler, because I think that's something that we need to consider. We need to make sure that we see short-acting beta agonist inhalers as something that people are using when they have symptoms to give them temporary relief, but they are a warning sign, and therefore they are rescue treatment. The second problem is that medicine isn't getting to the right place. So in the UK, we tend to prescribe metered dose inhalers, but we know that many of our patients aren't using these correctly. And often we suggest that people use spacer devices with their metered dose inhalants, but we also know that there's very low adherence to using a spacer device with a metered dose inhaler. And of course, all of this leads to poorer outcomes. So these graphs are showing you what happens when people are over-reliant on rescue medicine and not taking enough of their treatment medicine. So the rescue medicine, I mean short-acting beta agonist or the blue salbutamol inhalers. And you can see that as people go to more than 2 of the salbutamol inhalers a month, then the risk of asthma deaths increases quite significantly. And that risk goes up the more salbutamol inhalers they use. And it's important to know that the definition of SABA over-reliance is 3 SABA inhalers a year. And that's because if you're needing to use salbutamol for more than twice a week, then or if you're well controlled and you're not needing to use it more than twice a week, then you're not going to get through more than 1 or 2 of those inhalers a year. So having to use 3 or more means that you're having frequent symptoms, which is a measure of poor control. However, the opposite is true of the inhaled corticosteroids. So if we use more of that and we're dampening down the inflammation, then that is actually associated with a significant reduction in asthma mortality. And maybe we should start thinking about our inhaled corticosteroid as not just the treatment, but the life-saving treatment in asthma. So one of the things that has really changed my practice in the last few years is using an airways diagram to explain to patients what asthma is and how their inhalers work. So I will show them this airways diagram and I'll point to the normal airway, explain that the airways are the tubes that go into the lung, and if we were to cut them into a cross section, we would see that when a normal airway has lots of space in the middle for air to go in and out. But in asthma, that causes swelling in the lining of the airway, much like you might get when you have a cold, you might get swelling in your nose, and that reduces the space for the air to come in and out. Now, inflamed, swollen airways are more sensitive to triggers. So when you come across those triggers, and that will obviously be individual to the patient, then the muscles around the airway squeeze, narrowing the airway further. And that's when you suffer with those symptoms of cough, wheeze, chest tightness, shortness of breath. Now, when you use that blue inhaler, what that does is it relaxes the muscles around the airway, and it will work for a few hours and you will feel better, and it's taking you back to the inflamed airway. But actually, if we treat that inflammation with your preventer inhaler, or as I like to call it, the treatment inhaler, then that will reduce the swelling in the airway. That will get you back to a normal looking airway, which won't be sensitive and it won't react to your triggers. So that's the main treatment for asthma. It's the one which is going to keep you well. And what we want is for you to be symptom-free, no restriction on your activity. And it's been really interesting for me to see the light bulb moments for patients when they are actually explained what asthma is, what's happening in their airways, and how their inhalers work. So we can look at tackling that issue of making sure that people are getting their right medicine through some education. But the other thing, what else can we do? Well, GINA, and many of you may be familiar with GINA guidance. So GINA is a global organization that looks at the evidence around asthma treatment and makes recommendations for a global audience. And they looked at the evidence for asthma care back in 2022 and came up with this pathway where they said, and if you look at the top pathway, they have said that the preferred treatment for asthma should be combination inhaled corticosteroid and formoterol at all stages, and and then you have added on treatment when you get to step 5, rather than having separate inhaled corticosteroid and reliever inhalers. And why did they recommend this? Well, if I can just explain what's actually happening when people are on separate inhalers. So you've got a patient with an asthma who is exposed to a trigger which causes the inflammation in their airway to increase. They get increased symptoms and start to use their reliever inhaler more, their rescue inhaler more, and it makes them feel better transiently, but ultimately they reach a crisis point because the inflammation is not being treated by them using their blue salbutamol inhaler. So they reach a crisis point and then they might present to us in primary care or they might present in emergency care, and they end up needing oral corticosteroids, and those oral corticosteroids then reduce the inflammation. Now, of course, these oral corticosteroids are important, but as I said before, even 4 or 5 courses in a lifetime increases risk of long-term conditions. So it's something we would want to avoid. Now, in ICS formoterol combination inhalers, which are also called anti-inflammatory relievers, they have both the anti-inflammatory medicine, which is your inhaled corticosteroid, and formoterol. Now, formoterol is a long-acting beta agonist, but it's a fast-acting beta agonist. Now, not all long-acting beta agonists, not all LABAs are fast-acting, but formoterol is, and it's just as quick as salbutamol. So if you use an inhaler with inhaled corticosteroid and formoterol, well, you don't need any short-acting beta agonists. You don't need any SABA. And you can use this in 2 ways. So with people who have very infrequent or very mild symptoms, they may only need to use this inhaler when they have symptoms. And this is sometimes called as needed reliever therapy, air therapy. But also you can use it in a way that you're probably more familiar with, which is using it as a maintenance dose, which is usually twice a day, and using the same inhaler for relief of symptoms. And that's called maintenance and reliever therapy, or MART therapy, and that's for your moderate or severe asthma. And what happens when you're using the combination inhaler compared to if you're using separate inhalers? Well, again, the patient with asthma might be exposed to a trigger and they get that angry, inflamed airway, which is now becoming narrow, and now they're getting symptoms. But as they get symptoms, they're reaching for their reliever inhaler, which is giving them the relief with the formoterol, but it's also giving them additional doses of the corticosteroid, which is tackling their inflammation early. And if they're needing to take several doses a day, well, then they're getting several doses of the inhaled corticosteroid, which then prevents them from reaching the crisis point and prevents them having an exacerbation and the need for oral corticosteroids. And we know from lots of randomized control trials in adolescents and adults that this combination of inhaled corticosteroid and formoterol therapy significantly reduces the risk of people with asthma having severe exacerbations compared to using a separate SABA reliever and maintenance therapy across the spectrum of asthma severity. And this may be because actually in the real world, combination therapy, it overcomes that problem of low real world adherence to the preventive therapy. And it makes sure that even people who aren't adherent to their steroid therapy are getting it on the days that they're symptomatic and they're using their reliever. And also that the additional inhaled corticosteroid is being titrated as they're needing more. So it reduces the risk of exacerbations. It overcomes that real world problem. And then, of course, because they're not getting to the point that they're having the exacerbation of needing the oral prednisolone, it actually lowers the total dose of steroid therapy. So reducing those long-term risks. And it's just a lot simpler because you've only got one inhaler to remember, one inhaler to take if you're taking it regularly twice a day, and one inhaler to carry around with you. So many patients actually find it a lot more convenient. Now, many of you who are here will probably be aware that there is an environmental issue with metered dose inhalers, pressurized metered dose inhalers, and you may have heard of them as being a carbon hotspot. You may be aware that metered dose inhalers and their have propellant gases in them, which are hydrofluorocarbon gases, powerful greenhouse gases, thousands of times more powerful than carbon dioxide. And that, you know, from NHS England's point of view, if it's looking at its carbon footprint, that these pressurized metered dose inhalers are responsible for 13% of the carbon footprint related to direct care. You might be aware that only recently there were incentives in place to try and shift prescribing towards lower carbon dry powder inhalers. Now, the reason I put this up is really to just make it clear that by focusing on making sure that people are on the right medicine and making sure that the medicine is getting to the right place, we're actually tackling the carbon footprint automatically. Because if we look at where the carbon footprint comes from, the bar charts on the left are basically showing us that we are prescribing far more rescue medicine than treatment medicine, far more SABA than ICS. Now, we would expect the opposite in asthma if people were well controlled. We would expect them to be regularly needing to use an ICS, but only occasionally needing to use a SABA, and we would expect this chart to be reversed. But that's not the case. We're prescribing a lot more SABA than we are ICS. And that's where the greenhouse gases are as well. So there's most of the greenhouse gases come from the SABA part of the inhaler prescription. So if we can improve control and people don't need a SABA anymore, then we're tackling the larger part of that carbon footprint, 2/3 of the carbon footprint. And then if we just focus on making sure that people are on the inhaler that gets the medicine to the right place, then I think we're likely to make sure that people are moving to a dry powdered inhaler appropriately, and that will be the vast majority of people who need to move. And it's worth remembering that the UK is out of step with Europe when it comes to inhaler device prescribing. In the UK, 70% of inhaler prescriptions are for metered dose inhalers, which compares to a European mean of about 47.5%. And in Scandinavian countries, it's less than 30%. In Sweden, it's 13%. Now, we know that both inhaler devices are just as clinically effective. And dry powder inhalers have been around for a long time, but I know that I wasn't offering patients a choice, and I expect many of us haven't traditionally been offering patients a choice, probably because we're not that familiar with them. You know, we also know that we're not doing particularly well in the UK when it comes to our asthma control. But there's no clear correlation between inhaler device choice and mortality rates. So the British Thoracic Society position is that there must be clinically appropriate means by which to reduce the level of metered dose prescribing in the UK. So how do we make that choice? On what basis do we decide which inhaler device is most clinically appropriate? So in my clinical practice, I find that the key factor in deciding whether or not somebody might be suitable for a dry powdered inhaler is the type of inhalation that they're taking with their existing inhaler. And so it's more of a case of making sure that we are asking people to show us how they are using their inhaler. And if they are a patient who is using a metered dose inhaler, it's important to ask them in as open a way as possible if they're using a spacer device, because spacer devices are recommended with metered dose inhalers, although we know that spacer device use is low. And then getting them to demonstrate how they're using their inhaler, because with a metered dose inhaler, we need to have people press down on the canister whilst taking a very slow and steady inhalation over 3 to 5 seconds. So it's a... Whereas in my clinical practice, my experience is that most people are taking a quick and deep breath whilst they press in. So it's a... Now, that's exactly the type of inhalation you need for a dry powdered inhaler, where the medicine isn't propelled out, but it's your breath that carries it into your airways. And because of that, dry powdered inhalers aren't used with spacer devices. The other advantages are that dry powdered inhalers all come with dose counters, whereas metered dose inhalers, some of them do and some of them don't. And I remember that sort of when I started thinking about this, realizing that it was really quite interesting that we expected people to know when their inhaler is empty without a dose counter, particularly for the rescue inhaler where they're only using it occasionally. So unless people are literally tracking down how many doses they have, they're not going to know when they have any medicine left in their inhaler. And we also know this through studies that people with metered dose inhalers often throw away inhalers that have got half of their medicine still in them. And then from a clinical perspective, more worryingly, because sometimes propellant gas can still come out, there might be no medicine left in, and people are still using that inhaler. So dose counters are a really important clinical consideration. So in my practice, I would say that a large proportion of people with asthma are probably more suited to a dry powdered inhaler because it fits their inhalation technique than on a metered dose inhaler, which they might be prescribed. And my feeling is we should be fitting the inhaler to the technique of the patient rather than trying them to teach them to use a space device which they may not use, or a technique which they're finding hard to master. Now, one of the things that can really help us with this is becoming familiar with the lots of different dry powdered inhalers that exist there. Now, they do come in all sorts of different shapes and sizes, and they have slightly different techniques, but it's very easy to become familiar with how to use them. And there's lots of videos on the Asthma and Lung UK website or on Right Breathe that show you how they're used. And sometimes it might be helpful to also get inhaler training devices. So there's a diagram at the bottom there of an in-check device, which if the patient breathes in on it, will give you an indicator of whether their breath in was more suitable for a DPI, a dry powdered inhaler, or a metered dose inhaler, an MDI. And that can help build people's confidence. You don't need them. You can just use a placebo device or see how people are using their inhaler to make that assessment, but it can help. And then the trainhaler with the sort of the whistle diagram, that's really helpful if somebody does need a metered dose inhaler. So what I didn't mention in the previous slide was that there are some people who will need a metered dose inhaler with a spacer device if they've got severe disease, and when they exacerbate, they can't take a deep breath in, and perhaps very young children might also not be able to use them. And then, of course, there are some people who will prefer to use a metered dose inhaler, and we need to make sure that their technique is good as well. But like I said, we haven't been offering people a choice, and this is a slide that I've taken from Dr. Alex Wilkinson, and it's got a study on the left here from 2020 where patients were offered a very wide choice of different placebo devices to use, were trained to use them, and then were asked, which device would you prefer for everyday use? And although there was no single standout device winner, the majority of patients chose a DPI as the one that they would prefer to use. And many of these patients were metered dose inhaler users at baseline. Now, also, we know from surveys that have been done on thousands of patients that patients are interested in the environment. So when it comes down to a choice, if they can use both inhalers correctly, then they might want to think about environmental reasons as well. So let's go to the new guidance. What are the changes in the new asthma guidance? So we're going to look at diagnosis and treatment. I would say that the current situation is that under and overdiagnosis of asthma are both common. And in the old guidance, spirometry was the main confirmatory test. And the problem with that is, especially after COVID, there's often long waiting times. And because asthma is a variable condition and spirometry is a test of of outflow obstruction, if the person is not symptomatic at the time, then the test might be normal. And then also, patients with suspected asthma were often just started on a rescue inhaler, on a SABA inhaler, whilst awaiting spirometry test. Now, if there's a delay in waiting for the spirometry, that means that these people who might be at risk of an asthma attack are effectively without treatment. And then at the point of suspecting asthma, there's been quite a lot of variation in terms of whether or not that is coded as suspected asthma, and then what the process is in the practice of how those people are followed up. So are they followed up by the person who has seen them initially and has suspected asthma? And then what if they DNA? What is the process of making sure that we don't lose these patients and they don't just end up having lots of blue inhaler because they came in once and were given it, somebody suspected asthma, didn't code it. There has been quite a lot of underdiagnosis in that sense. Now, I think there's been a real improvement and shift in what NICE BTS sign guidance is now saying about diagnosis. And one of the things that's really reassuring is the clarity that asthma is a clinical diagnosis. So they have emphasized this to say that it's a clinical diagnosis. It's so important that we look at the history and the examination, and we need to treat the patient and not the test, because there is no perfect test in asthma. It's far more like a jigsaw. If we have a high clinical suspicion, then the tests are really just there to help us confirm our clinical suspicion. And what is it that we're looking for in history? Well, recurrent and variable symptoms, identifiable triggers. Is there a family history, or does the person have a past history of atopy? So what I mean by that is hay fever or eczema or maybe food allergies. Is there not really any other good explanation for their symptoms? And on examination, if you hear a wheeze, then that's a very strong sign that it's probably asthma. And then the other shift is that instead of looking for markers of variable airflow obstruction, we're now looking for markers of inflammation first. So the first test that NICE, that the new guidance recommends, is either blood eosinophils or fractional exhaled nitric oxide, which is a marker of inflammation of the airways. So that's a change. So spirometry is not the first test, spirometry is the second test. The third thing that they've done is they've looked at preschool kids. So, and it was quite common for us to feel like we can't possibly diagnose children under 5 with asthma because, wheezing with viral infections is really common. But some of these children will have asthma. And if we suspect it for the reasons above, then it's important that we give them a trial of treatment, because tests are not considered particularly accurate. And the other thing that they've made clear is when we should be referring to respiratory pediatricians. So if they've been admitted to hospital or had 2 admissions to A&E in 12 months, that's high risk. And we should be referring those children to respiratory pediatricians. So some really clear guidance there about what we should do. The other thing they've said, which we're really pleased about, is they've said we should be coding people who we suspect with asthma as suspected asthma, and made it really clear that we don't wait for the test to treat if somebody is symptomatic. So there's some really good, clear guidance there that we hope will improve people's, both the diagnosis, but also whilst people are waiting for diagnosis, make it a lot safer. And what NICE have done is they've created some lovely flow charts to help people know what they're doing and in which order. And they're pretty self-explanatory. Now, the diagnostic pathways are aged 16 and over, and then they're for children 5 to 16. So if you're 16 and over, The first test is either blood eosinophils or FeNO. FeNO ideally at point of care. And it can be a point of care test. So if you've got it in practice, that's brilliant. If you suspect asthma, you can check if somebody's, you can check someone's FeNO level, and if their levels are high, then you can diagnose asthma instantly. But you can also look at blood eosinophils historically. And then if that's negative, then you can go to the bronchodilator reversibility with spirometry. If that's delayed or not available, then they have put peak expiratory flow variability as well. And I'm sure some of us are grateful for that in primary care if we don't currently have access to FeNO or spirometry, and if the eosinophils aren't conclusive. And then if none of those tests help you and you're still suspecting asthma, then that's when you refer to secondary care for a bronchial challenge test. And you might also want to consider if it might be something else. In children, the difference is that it's FeNO first, not blood eosinophils. So you don't have blood eosinophils as your first test. FeNO is your first test. Then it's spirometry. Then it's peak flow variability. And then after that, you're either doing a skin prick test for house dust mites, or you're doing a blood test for inflammatory markers, which is total IgE and blood eosinophils. So slightly different for children. So what does this mean in practice? And I've just written down a process that I think might be helpful for us to think about, and something that we're doing in our practice. So the first thing is that if I suspect asthma, coding suspected asthma in the notes, and I tend to explain to patients what I'm suspecting and why, and I'll show them the airways diagram at that point. And then you need to, obviously, it depends on what tests are available to you. FeNO, ideally, if you've got it as a point of care test in adults and children. Full blood count for children over children and adults over 16. And I do find it useful to look at old eosinophil count. So you might have had a very high old eosinophil count and notice that somebody has suspected asthma in the past as well. That can help you diagnose it as well. Then you might be referring to spirometry if that doesn't help. But at that first consultation, I will also do a peak flow and give one to the patient to record for 2 weeks. Even if it doesn't help with the diagnosis, I find it's helpful for self-management later on, and it can help with the personalized asthma action plans if you can get a sense of what someone's baseline peak flow is, and actually even seeing if they've got a low baseline peak flow when you're suspecting asthma, and if you need to do a trial of treatment and it gets better, then that can also help you make the diagnosis. Then I prescribe ICS formoterol inhaler as needed as a reliever. So the new guidance clearly states that no one with asthma or suspected asthma should be on salbutamol alone. So this is a clear change in practice. So at the point that you suspect asthma, you're not giving someone a blue inhaler, you're giving them a combination ICS formoterol inhaler to use as needed, and then hopefully you can get the investigations as soon as possible. And also giving them information on how to use that inhaler and what to do if they have an asthma attack in the meantime. And then you're organising a review with the test results, and have a system for follow-up if they don't attend. So that might be that you bring them back if you're the one who suspected, or if you're going to ask them to come back to see a practice respiratory nurse, you might need to write down why the reason for why that person's come in, so that if they're not attending, there's a process for following them up. What about treatment? So we've already talked about how at the moment we've got lots of patients with uncontrolled asthma. We've actually got lots of patients on SABA alone, which used to be step one. You know, it used to be what we said, but we, you know, like I said, the guidance is really clear that nobody should be on SABA alone, because being on SABA alone is basically not being on treatment. Most of our patients are currently on separate inhaled corticosteroid and SABA inhalers. And that means that because of what we said with adherence to preventer inhalers, actually most patients are effectively not being treated, and a lot of our patients are over-reliant on that rescue treatment. And then most of our patients are on metered dose inhalers, and we've got that problem with inhaler technique, spacer use, not knowing when the inhaler is empty, so that might mean the medicine's not getting to the right place. So in the new guidance,
say your 5-minute warning. Thank you.
Brilliant, thank you, Katrina. So in the new guidance, it says no one with asthma or suspected asthma should be on salbutamol alone. Combination ICS formoterol inhalers first line for people who are 12 years and over. And I'll go through the diagrams in a minute. It's even gone further and said, even though we haven't got any randomized control trials for this age group, that we have 2 pathways for 5 to 11-year-olds. So you can continue with the separate ICS and SABA, or if you think a child can cope with a maintenance and reliever therapy regime, you could start that as well. Now that's off label, but NICE have said that that is an option. And they have specifically clearly said that inhaler device choice should be based on assessment of technique, patient preference, environmental impact, and dose counter. So just to let you know that there are some really good diagrams which show you this in practice, some really good flow charts. So this is the one for pharmacological management of asthma in people aged 12 and over. So the treatment algorithms are 12 and over and 5 to 11, whereas the diagnostic ones are 16 and over and 5 to 16. And I think it's also really helpful that they have put down what uncontrolled asthma is, and we've been through that before. And I'd say that they've gone even further than GINA. So if we just zoom in, they're now saying that if we've got newly diagnosed asthma in someone who's 12 or over, we should actually just go straight to combination inhalers. If they've got very infrequent symptoms, then we'll go for air. But if they're highly symptomatic or they've got severe exacerbations, you start with maintenance and reliever therapy. You can increase the dose. And then if they're still not controlled, at that point, you might want to check their markers of inflammation. If they're raised, you might want to refer them. But if they're not raised, you might want to then add in a LAMA or a leukotriene. So Montelukast medicine. And then just adding in the bit of what do we do with our existing patients. So it's really clear. It says here, if we have any patients who are only on SABA, we should straight away move them to air therapy. If they're on separate ICS and SABA and they're not controlled, then we should be moving them to low dose MART. If they're on moderate dose with separate SABA, then we move them to moderate dose MART. So it's quite straightforward, but given that we know that a lot of our patients are uncontrolled, I would say that as we're reviewing our patients, we should be expecting to move many of them over to combination treatment. And this is the one in children. I'm not going to go through this in detail, but just to say that there are those 2 options. So how do we put this all together in a consultation? Well, just to let you know that there is a video on the Greener Practice Asthma Toolkit that takes you through all of this. And we're currently in the process of updating the toolkit. So it's very much in line with the new NICE guidance, and that will be completely available from April. But we've also got a visual aid for optimizing asthma reviews, which is pretty much already in line with the new guidance. And there's 2 sections to it. There's the bit about making sure that people are on the right medicine, and we've got lots of prompt questions here to help you have that conversation with patients, to help you make sure that you are looking objectively to see what they're actually doing in terms of preventer and reliever use. Explaining what asthma is, having that conversation about combination inhalers and making sure they know what to do in an emergency. And then this bit, we just wanted to make sure that people started that conversation about making sure people are getting the medicine to the right place by looking at how do they use their inhalers. So we suggest you start with the question of show me how you use your inhalers. And then if they're not using the pressurized metered dose with a spacer, or if they're using a quick and deep breath in, a DPI might suit you better. Or if they're using it correctly, but they don't know when their inhaler is empty, and they might still be better with a DPI with a dose counter. And it's only at that point that we talk about whether or not they're interested in an environmentally friendly choice. So my top tips are Tests don't make a diagnosis of asthma. Make sure you treat the patient, not the test, and recognize that diagnosis is putting together pieces of a jigsaw. So you're putting together your clinical suspicion with the tests. Make sure that everyone in your practice understands there is no place for SABA alone in asthma at any point. Really spend time increasing the expectations of your patients. You know, I often say we can do better for your asthma. Make sure that you explain asthma, use that airways diagram, and consider the use of metaphors. So a metaphor that I often use is, you know, we wouldn't just give you more and more GTN spray if you kept getting chest pain. We'd want to bring you back to make sure that your angina was well controlled. So you can consider using those kind of metaphors. Really become confident with promoting combination inhaler regimes. You know, I've heard in the PCRS webinar, they talked about calling it an upgrade, and that can be really helpful. And then develop your confidence with the inhaler devices. My top tip would be to get placebo inhalers in your practice so you can show people the different options, and consider inhaler training devices and using inhaler videos. So I'm going to stop now and hand over to Veena, who's going to talk to you about implementing this work in practice.
Thank you so much, Artie. That was an amazing overview of the new guidelines and the rationale behind them and how much difference they're going to make. So next, we're going to have Dr. Veena Agrawal focusing on a quality improvement project in asthma care, which she undertook as a GP registrar. So Veena is now a newly qualified GP in Battersea in Southwest London. She previously did a one-year sustainability fellowship at Greener NHS in 2021, and she co-chairs the Greener Practice Trainee Forum and South London groups, and also co-leads the RCGP Sustainability Group. But today she's here in her capacity as a frontline GP, talking about what she learned from a QI project reviewing SABA overusers while a registrar. Veena, do you want me to share your slides if you're still having trouble? Okay. Veena, are you there? I think Veena's having some technical issues. So we'll take this opportunity to have a look at the Q&A that's been coming in so far. Artie, I think one question that came in that sort of aligns with what you were just finishing off with was about how to explain sort of MART or combination inhaler use to patients who might be very attached to their SABA inhaler after using it for many years, and patients feeling very reluctant to give up something they see as life-saving. So how do you sort of, you know, persuade them of the benefit?
Yeah, so I will just spend some time saying it's, you know, you've got both medicines in one inhaler, and this medicine is not just as fast working as the salbutamol inhaler, but it also works for longer, so it's actually better for you. You know, I'll often say that this is the new recommendation. This is new treatment. I might even suggest that it's a little bit more expensive, but we think it's better for them to try and persuade them to do it. But Deb and LJ, have you got any thoughts about what you say to people to try and persuade them when they're very attached to their blue SABA inhaler?
It can definitely be a challenge, and I think one of the things to recognise is that this is definitely a shift for patients as well as for clinicians. So we're all kind of on that journey together, and it will take some time for this to be normalised. But as you've done, I do very similar. So I tell them that actually treatment for asthma has evolved, and that's a really good thing. Our evidence now is much better, and we know that most people do better on a combination inhaler, and we want to make sure they're getting the absolute best care, and that this was what we would recommend to have the best control, and that our expectation is that this will mean that actually they take less medicine overall, and that their symptoms are better controlled. And that's what we'd hope for them, that actually asthma is not something that should affect you every day. It's something that should be well controlled, and you should be able to crack on with your life. And so I think some of it is setting expectations, because people often have got used to being limited. And so that conversation could be very helpful. But it looks like Veena is on now.
Oh, guys, I'm so sorry. Can you see and hear me?
Yes, we can.
Yeah,
and while you get set up,
My computer crashed and I couldn't turn on my camera and mic, but I'm here now. So hi everyone, and thanks Artie for your brilliant presentation. And I'm glad you were able to do a Q&A while I was just getting back on. So
yeah, and
thanks
we'll
for
return
that.
to the Q&A after your presentation, Gina. So great that you're showing us how a QI project can improve asthma care, which you did as a registrar. So we'll return to the Q&A after this. Thanks, Gina.
So hi everyone, and thanks so much for giving up your Wednesday evening to come and join this. So thanks for the introduction, Katrina. I won't say all of my roles that I'm doing again, but I've just qualified about a month ago as a GP and I work in South West London. I did a project as a GP registrar on tackling SABA overuse, and the reason I'm talking about this project in the context of the NICE guideline is because even though the guideline only came out about a month or two ago, a lot of the principles that are in this guideline, as Artie has said, were already in the international guidelines. So quite a few of us from Green in Practice have actually been trying to practice in this way even before the guidelines came out. So I do think the project is relevant to the guidelines and how we can improve asthma care. So I have no conflicts of interest to declare. So before I start talking about my project, I want to talk about the whole team approach, because I just want to say that the project that I did is not the only way of improving SABA overuse and improving asthma outcomes. We do need to think about the whole team and who is going to be involved. And many of you will know this because you're interested in this topic and you're here already. But I do hear from a lot of people that, well, GPs aren't relevant to asthma, it's just the practice nurses and pharmacists do the asthma reviews, or, you know, things like that. And I just wanted to say that actually there are a lot of different opportunities to consider people's asthma control. So it might be when someone comes in with their initial symptoms, and that's usually a GP or another clinician who sees them. It might be that they're repeat medication prescribing, the request comes through when you're clicking through all your repeats. So that might be come through a pharmacy. It might be that reception staff pick it up, the practice pharmacists or the doctors who are approving the repeat prescriptions. It's a great opportunity to identify when someone's control may be less good. And then there's also the medication reviews, which are often done by doctors or non-medical prescribers. There's the asthma annual review, which is often done by practice pharmacists and nurses. And then we've got the admin side of how people are recalled for that. And then there's also when people have emergencies like exacerbations and the follow-up from that as well. So we do need to involve a whole team, and that's not just our clinicians, but also some of our admin team as well. The Asthma Toolkit is how I managed to do this project, because it is a fantastic resource and I highly recommend it. This is on the Green in Practice website, and this is a resource that's got a lot of projects and it's got so much information that can make it really easy to do this. So what's in the toolkit? We've got multiple project ideas, so you can pick and choose what you want to focus on. There are 4 areas that have been focused on the most, covering correct diagnosis of asthma, control of asthma, making sure people are on the right device choice, and also disposal. Because it's quite quick and easy to message everybody to say, can you dispose of your inhaler in the pharmacy rather than in the bin, which is better for the environment. Some of these projects are quicker and easy, others are more involved. And there's a lot of resources in the toolkit which can really help to make the project a lot easier. So there's the information on what to do step by step. There's also the downloadable searches, which can work in EMIS and System 1, and I'll show you what those are in a minute. There's a lot of educational videos, including a 9-minute model consultation, which is brilliant to show how this can be done. There are draft messages that can be sent out to patients for lots of things, including invite to a review or different things. There's posters you can put up in the practice, and also patient information in terms of leaflets, videos, and things that can be sent out to really help to upskill and educate our patients about this more. So I'll just give a brief overview of what we did in the project, and then I'll go through a bit more detail step by step. So we realised that the first thing we needed to do in the practice was to do an education session for our clinicians, so that everybody was kind of practicing in a similar way, understood the project, and just to kind of help them to change their practice as well. We then downloaded the searches to EMIS, and we looked at how many patients we had and worked out who we were going to invite. We contacted our patients and we decided to review most of the SABA overusers using over 6 salbutamol per year, which is not everyone who's probably overusing SABA, but it was the kind of highest ones to start off with. we did a kind of change from Ventolin to Salamol, which many of you may know is one that's still PMDIs for salbutamol, but it's a lower carbon footprint one. So that's quite an easy one to do, but it's not the final solution because it doesn't completely look at the clinical side of it, but it is just better for the environment. So we did that. And we also did a mass text to everybody who are on inhalers, not just on asthma, to ask them to dispose of their inhalers in the pharmacy. So that was kind of an overview of the project. So just to start with education for clinical staff. So what I did was I did a presentation. We had a lunchtime meeting, we had a weekly meeting, and we said, let's use one of those meetings to do this teaching. We informed everybody in advance. I developed a slideshow and did the presentation because I feel quite confident on this topic, having done it quite a lot in my fellowship. But for those who might not feel as confident, you could use the videos from the asthma toolkit and just watch them as a team, because actually they've got pretty much everything you need to know. And as Artie said, they will be updated as well. So that's a good way of just getting everyone on the same page. And then in terms of how to find your initial data, I wanted to mention the Open Prescribing website, because this is a website which takes NHS prescribing data and lots of different domains. Inhalers is one of them, and it shows you what your practice or your PCN or etc. ICS or national data shows. So you can look at the proportion of MDIs, you can look at the carbon footprint of your inhalers and a few other things as well. There is about a 3-month lag, but it's still useful to see what your trend is. And it can actually be quite a good way of motivating the team, saying, look, we've actually made an improvement a couple of months ago. And then people know that they're actually, making progress. And then there's the searches, which I mentioned, which can be downloaded from the toolkit. And they show you quite a few different domains. So how many patients have got asthma? We had a practice of about 13,500 patients. So we saw how many have got asthma, how many have been on less than 3 inhaled steroids, how many have been on 6 or more SABAs, 2 more courses of oral steroids, etc. There's quite a few different searches you can get. So that's a good way of working out how are we going to manage this. And my tip on that is that it does look quite alarming to see that you've got over 100 patients on more than 6 SABA. You think, oh my God, how are we going to do this? But what I would say is don't be alarmed, and don't also feel bad that, oh, we've not been managing this correctly, because it is complex. And a lot of that will depend on your population as well as how you've been prescribing. So it's not, don't think, oh no, we've done a bad job. It's just, it is hard. But you know where your baseline is, then you can start to recall. So what we did was in the teaching, it was really good to see who was really enthusiastic about this. So get your team together, think about who do we want to really push this forward. Whilst you want to educate everybody, but you also want to find the keen people who might want to do a project like this. So we found there was 3 GPs, the pharmacist and one of the practice nurses who really wanted to be involved in the project. So we thought, how, in terms of our practice management, how can we do a sustainable number of patients to see each week? So we thought 10 a week would be roughly 2 each. And one of our admin staff have really helpfully called the patients for us. And he brought them in. But we didn't take into account the fact that not everyone was going to come for various of their own reasons. So we probably only got just over half of the patients each week initially. But what I would say is we then started to think about, why are some of the patients not coming in when we've recalled them? And as Artie said, a lot of patients don't realise their asthma is poorly controlled. So they might think, well, why do we need to come in? And also some of them think maybe we're going to take their inhaler off of them, or they're going to be in trouble or something like that. So we thought maybe we need to send an FAQ document to them when we're recalling them to explain what's the reason, what we're going to do. We're not here to tell them off or to take their inhaler away. We're just here to support them and to improve their asthma. And what I did find was that when there were some patients who I was concerned about who hadn't come in, I actually called them myself and I said, I'm Dr. Agrawal, I'm just calling about your asthma. Initially saying, I noticed you've used a lot of your blue inhaler. It didn't go down well, so I stopped saying that. Just saying, I want to talk about asthma. How's it going? What are you doing with your inhalers? The reason we're calling is because we think we might be able to improve your asthma because of the number of inhalers you've needed. Can we bring you in for a review? And that only takes a couple of minutes because you're not doing a full review on the phone. You're just explaining why you need to see them. So that's my tip on that. Now, before I explain what we did in the reviews, I just want to mention a case because I think cases are a good way of illustrating the problem. And there were quite a few different cases I could have chosen who have similar but different stories. And this is a 14-year-old boy. His name isn't Jack, but let's call him Jack. So he was called in and he'd not been for an asthma review for over 3 years. He'd actually requested 14 SABAs roughly in the last year, and he hadn't had an inhaled steroid for 6 months. His asthma control test score was 14, and as many of you know, that's quite poor. When I asked him what he was doing with his inhalers, he said he was getting his blue inhaler. He came in with his mum, and she said he gets his blue inhaler. He was showing me. He went 1, 2, 3, 4, 5 puffs, and then breathed out afterwards. And he was doing that twice a day when he got up and before he went to bed. And he was also doing the same thing when he did sport or just at random times during the day as well. And he was using a short, sharp breath in, which, as Artie said, is a dry powder inhaler technique. And he was also doing all these puffs at the same time, which you shouldn't do. He wasn't using his Clenil steroid inhaler because he didn't think it worked. And at the first appointment, we just had this discussion about why, explaining the airways diagram, explaining what the Clenil is, why it worked, giving him advice, explaining why using a lot of blue inhaler can actually make your airways more sensitive, because there is evidence to show that it can actually worsen your airway sensitivity. And then we reviewed him again after about 1 to 2 months. Unfortunately, Jack was really struggling to change his behaviour, and his mum said she'd really tried to encourage him not to use the blue inhaler, to use the brown inhaler. It wasn't working. He didn't want to. He was just in this habit of using the blue inhaler in this way. So what we agreed to do with the mum and Jack is to try the MART regime. So that was ICS formoterol, Symbicort. We'd use it twice a day, and also when required if he had more symptoms. And we actually agreed to take the blue inhaler away and just use that one instead. And actually, we saw a really good improvement in Jack. So after 2 months, we saw him again. And actually, his asthma control was a lot better. He wasn't getting the same symptoms. Because he didn't have the blue inhaler that he was in the habit of using, he was using the combined inhaler twice a day and wasn't using it very often when required. And his ACT score had gone up to 24. So this is the kind of thing we want to do. And actually, whilst it was quite hard work and it was a bit concerning about how he's using inhaler, I hope that now we've set up him for the rest of his life to have much better asthma control and the rewards that will bring. And actually what was really nice to see was that he was doing a lot more sport, and because he was a bit overweight initially, he'd also lost more weight because he was able to be more active. So that will prevent other diseases in the future. And I saw that with quite a lot of patients. When we improved their asthma, they could improve their diabetes or other conditions because they could be more active too.
Gina, just your 5-minute warning.
Thank you. So Artie talked a lot about what we do in the review, so I'm just going to whiz through this because you know this now. But some of the things we need to do is make sure they have an ACT score done, and you can do that before by sending them a questionnaire or in the consultation, and we want it to be over 20-25. Find out about their symptoms, find out about their exacerbations. Make sure you're looking at their technique, and we tried to ask them to bring in their inhalers to the consultation because I found that was the most beneficial way of assessing them. But if they would forget, then we could use the inhaler training device, and they cost about £30 each, and I found them quite useful in the consultation when checking patients' inhaler technique, because you get them to show you on that like they would with their inhaler. I just asking a broad open question: which inhalers do you use and when? Gets to find out about the adherence. Explaining the role, as Artie's talked about, this education is so important, because I found that a lot of the patients were saying, oh, I've had asthma since I was like 3 and now I'm 40 or something. So they might not have this explained to them for a very long time. So that's why we have to use this diagram and explain it to them, and it's really helpful. Assessing risk factors like the triggers, smoking, air pollution, mold and damp, all of these things are important and can worsen the asthma as well. So we haven't got time to go into them in as much detail today, but it's worth just thinking about them too. And you might not be able to address everything in full in one consultation, but you can bring them back if there are issues. So educate them on this air and MART regime and why formoterol works quickly, using air and MART therapy. The videos from Asthma Lung UK are really good. So what I tended to do in these consultations were to say, this is how to use the inhaler. I'm going to send you the video, send it on an AccuRx, and say get a family or friend to watch it with you and just check you're doing it right in the first instance. And what we did was we set templates up in our practice so that if we want to send them, say, a turbohaler video, we could just click it and send it rather than having to get the link up every time. Remember to step up and down, because I found there was a lot of patients who were randomly still on a paediatric dose of their inhaler when they were an adult because it hadn't been reviewed. Or similarly, some patients were randomly on a huge dose of an inhaler, and that had just been on there for a long time, and they didn't need to be on a high dose for any particular reason. So just make sure you're familiar with what the doses are. And I would say, you're never going to remember all the inhalers and all the doses. Even after doing this a lot, I don't remember. So get the table up. There's one on the Green in Practice Toolkit resource website or on the NICE guideline, because you can see what's low, what's moderate, what's high dose, and then you know what's equivalent and how you step up and down, because it's not the same dose for every inhaler. It's a bit confusing, so just look it up. And just try and make sure if you do change something, that you do review them in 8 weeks, and that, or roughly 6 to 12 weeks. It can be hard to get them back, so just try and have a process for someone to call them back in. And just pick a couple of favourite inhalers of the ICS formoterols that you use. I won't promote any brands today, but I have my 2 favourites that I use. So then it's easier to remember which ones you're going to use. I'm just going to do another 2 minutes if that's okay. There's a couple of common patient concerns, and it's good to actually try and address these before they come up. So a lot of patients will think a dry powder inhaler doesn't work because they can't feel that whoosh going to the back of their throat, which they're used to with the MDI without the spacer. It's worth saying before you give it to them, this isn't going to feel that whoosh, and that's good because it's not hitting the back of your throat, it's going into your lungs. Then they think it's good and they don't come back complaining. Just tell them it will taste different, because then they're expecting that. I found a lot of patients are afraid of taking inhaled steroids because they think it's like tablet steroids, and there's a lot of, concern about that. So if you do sense any hesitation, just say, do you have any concerns about inhaling steroids? And then explain that actually on low to moderate doses of inhaled steroids, there is really minimal absorption into the body, and that yes, tablet steroids are a concern, but they're much less likely to need those if they have the inhaled steroids, which mostly just work on the lining of the lung. And that really helps to improve the adherence as well. So I really recommend doing a project on this because it's a really common condition, asthma. We actually really have the potential to make massive differences to the outcomes for our patients, as well as reducing the carbon footprint. We can also reduce our workload because if people have less exacerbations, that's only good. People don't have exacerbations when they have well-controlled asthma in general. They only really have exacerbations if their asthma is already not great. And I would also say that it might sound like a lot now, but once you use the toolkit and go through it, it makes it very straightforward. And once you've done this a few times, actually, it's quite simple. So in terms of my results from the ST2 practice that I was in, ST3 practice, sorry, I should say, we got the salbutamol carbon footprint down really quickly. The MDI, the proportion of MDIs came down more slowly. You will ask why it has come back up, and that's because I did the teaching in October 2023, and after a while there was some staff turnover and people I didn't manage to get to do the teaching with, and some locums and things. So that's why it probably went back up again. But we did make progress. So I would say this project was really, for me, it was really transformative, and it felt really satisfying to actually see people get better. There are other things you could do in your practice as well. So looking at some of the processes like 48-hour follow-up, how do we recall people who haven't responded, diagnostic pathways, just looking at what's going on there, and how you manage your repeats as well, and to check for SABA overuse. So I'm going to stop there because I've just gone over my time by 2 or 3 minutes. Sorry about that. So I'm just going to say thank you for listening. Thanks for having me. And if you want to contact me about the project and have any personal questions, then there's my email address. Right, I'm going to stop sharing.
Thank you so much, Vina. Great. Well, I know there's lots of questions in the chat, so I want to make sure we try and get to as many as possible. And now I'm going to invite Artie, Vina, and our 2 other panelists for Q&A to come on screen when they're ready. So we also have Deborah Lees joining, who's clinical lead pharmacist for respiratory at South Yorkshire ICB and co-clinical lead for children and young people's asthma for the South Yorkshire Children and Young People's Alliance. She's also one of 6 Asthma and Lung UK respiratory champions and vice chair of the Primary Care Respiratory Society Service Development Committee. Good thing I just had my anti-inflammatory reliever before this to get all that. And we have Dr. LJ Smith joining us, who's respiratory consultant at King's College Hospital, co-chair of the South East London Responsible Respiratory Prescribing Group and board member of the British Thoracic Society. And LJ is leading work on local asthma guidelines to implement national guidance into secondary care and emergency departments. And LJ, I might put the first couple of questions to you. There's quite a few questions around spirometry and what the move to combination ICS formoterol will mean for spirometry. So to put a couple of questions together, if a patient has already started any form of ICS, does this make spirometry more difficult to interpret? Could it be normal as they've already started treatment? How many hours do people have to stop their ICS formoterol before spirometry? And then finally, can an air inhaler, anti-inflammatory reliever, be used for peak flow reversibility testing in diagnosis? If you can.
Thanks very much. So great questions. Okay, lots to cover. Okay, so a major worry that people have is that if they see someone and they suspect asthma and they treat them as asthma, that will then mess up the test and then they won't ever be sure if they've got asthma or not. And I think I totally understand that worry, but I don't think it's a problem we need to worry about. So if clinically you use your clinical judgment and on the basis of someone's history and the initial test you have, then you think it's most likely to be asthma, they absolutely need to be treated as asthma. And in that case, we would be recommending that they're started on a combination inhaler. And as Artie said, if they have very infrequent symptoms, that would be air. So that's just as and when it's needed. And if they have more regular symptoms or have had any exacerbations, we would say give them MART, which means regular plus as required. Still one inhaler, a combined ICS lab with formoterol. When they then come to their spirometry, there is a potential for that medication to impact on that test. That is a less bad outcome than them not getting any treatment and risking an exacerbation. But for most people, it won't have any impact on their test, because what we would advise is that they try not to use their inhaler, certainly for 24 hours before the test. So our lung function department won't do reversibility if they've had it within 24 hours, because then it's not a meaningful test. But what we say to our patients is, if they're on air, particularly, if they try not to take any doses for that week, and if they're on MART, if they can try and have 24 hours minimum, 48 hours maximum. Now, if they're taking a lot of that, then it still might reduce their reversibility and their pheno. But if those two things are really bad, we'll still see an impact, particularly with pheno. If their pheno is sky high, if their inflammatory markers are really high, then it will still not be super suppressed. So we can still use that information. Even if we have a negative reversibility and a low pheno, but clinically we still suspect asthma, the guidelines are very clear about this. They say that that's the point at which we should be doing challenge testing. And that is new in these guidelines and is a pressure on secondary care and on spirometry, because we haven't done loads of challenge testing. So that's a challenge for us, but that's for us to sort out. But the most important thing is that the patient is getting the right treatment based on your clinical diagnosis. And what we're all doing all the time is taking all the information we have and making the best judgment that we can. And then the question about whether we could use the combined ICS formoterol for reversibility testing, I guess theoretically, yes. It's not quite as quick acting as salbutamol. So by, I think it's 2 minutes in the data that's published, it's exactly the same efficacy. But within that very first minute, salbutamol maybe has the edge. But it's not in any guidelines for example, from the ARTP. So we're not going to be doing that. We're still going to be using salbutamol for reversibility testing. That's a test, that's not treatment. So that's a whole different thing. So I wouldn't really worry about that at all. I think that was all the questions.
Yeah, great. Thank you. Great. And there's next a couple of questions about sort of rescue use. And what the move to ICS formoterol means in a sort of rescue scenario where previously we might have told them to take 10 plus of SABA and a spacer. And so I don't know who wants to come in on that. How would you advise somebody in an emergency if they needed to use their ICS LABA?
I don't mind coming in on that one. I think that when we are implementing air and MART regimes, we should really very much try and keep people on that inhaler and not give them a SABA alongside it, because if we do that, we do promote that bad behaviour and they go back to using that SABA all the time. And the whole idea of using the air and MART approaches is that they are inadvertently increasing their own inhaled corticosteroid dose and dampening down that inflammation that's there. That doesn't happen if they revert to using the blue inhaler. So very, very much promote using ICS formoterol in an emergency. There may be some exceptional circumstances, maybe in children or for people who you have given them a dry powder inhaler and you fear that they may not have the inspiratory effort during an asthma attack. To use that dry powder inhaler. I must stress that these are rare instances, And actually, I would probably say that somebody who has a PMDI without a spacer is probably less likely to get the drugs in their lungs than if they had a dry powder inhaler. But in those exceptional circumstances, you may want to supply a one-off salbutamol inhaler, but it's an emergency inhaler, and that's simply what it is. And it certainly shouldn't need to be ordered repetitively, because if it is, that's an awful lot of emergencies that person is having. But the best advice really would be to stick with the ICS formoterol wherever possible as that emergency inhaler, so they're getting the benefit from that anti-inflammatory treatment. In terms of the number of doses that you can take, so the license is in an emergency, you can take up to 6 puffs of the ICS formoterol containing inhaler, usually at intervals of around 1 to 3 minutes. I would very much say that if you look at something like the Asthma and Lung UK plan for maintenance and reliever therapy, it even says repeat that step. Obviously, if you're getting to the point where you repeat that step, you are effectively going off label with that medicine. But if that's an emergency and that person is potentially going to die, a few extra puffs of ICS formoterol is not going to do them any harm in that circumstance, and they should just keep taking it until they get that emergency help that they need.
Great, thank you.
Can I just add one thing to that? So I think this is a really common worry, and that was really brilliantly explained there. The thing I would say is that we have to remember that there are other places that have been using the combination inhalers maybe are further ahead than we are as a kind of nation, and that they are not seeing problems. And those regions that have really pushed this, so many local guidelines already use a lot of combination inhalers. Southeast London is one of them, and there are many others across the country. And there has been anxiety about, well, what if people are in an emergency? And what we find is people can use the combination inhalers absolutely fine in an emergency. There's no difference in their outcomes. If they need to seek emergency care because it's not working, they do so, and they need to do so just in the same way as if their blue inhaler wasn't working. And actually, the chance of them getting to that point where they're so bad is lower because they've had more ICS. So it's a really common thing and really understandable worry, but in practice and in the data, we're not seeing any problems. So we should really be very confident in recommending to our patients that they should use the combination inhaler as a rescue treatment.
There's a couple of questions about COPD and how it influences our management if a patient has asthma and COPD or asthma COPD overlap. LJ, do you want to take that as well? Or,
yeah. So again, this really comes down to a judgment call. So none of this is black and white. People don't come with a nice happy label of asthma or COPD, and people can have both. And loads of my patients have both, because you're more likely to end up in secondary care if you've got both, because it gets more messy and tricky. So loads of my patients have asthma from childhood and then have smoked and have got a degree of fixed airways disease, but have also got some reversibility and some provoking factors, but behave a bit more like COPD or a bit more like asthma. It gets really messy. The important thing is to treat the kind of driving factors that are the problem for that patient's disease. So if I see a patient and they've got a label of COPD and they behave like COPD in that most of the time they kind of have up and downs, but they're stable, they don't have a lot of reversibility, and they don't really have attacks in the same way except when they have an infective exacerbation, and they've got a good smoking history, blah blah, but their eosinophil count's a little bit up, I'll probably mostly treat them as an eosinophilic COPD. And increasingly, we're looking at that group, and in the future, that group will be offered biologics. But that's really like kind of getting into the very much secondary care, tertiary care type care. If a patient has a much more asthmatic type phenotype, even if I know they've also got COPD, as in they've got some fixed airway disease and I've seen their CT scan and they've got emphysema, if they keep coming to A&E because they're getting flare-ups, if I can see that their pheno is high, if I can see that their eosinophil count is high, or if they tell me that they're triggered by air pollution or by a dog, then I'm going to treat them like asthma. And what that means is I'll give them a higher dose of inhaled corticosteroid. So this is all down to clinical judgment and taking the evidence that you have and then making a judgment. So at the point where you're sort of starting off and you're not sure what the diagnosis is, I would say the safer thing is to treat as asthma. So if you're really not sure and you really can't work it out, treat as asthma, because the worst case is you're going to slightly over treat them with steroids if they've got COPD. Then you're going to get the tests and you're going to figure it out, and you're going to then tweak your regime, and that's absolutely fine. And if it's still not clear, please do refer in, use advice and guidance, use your local respiratory specialist. But at the beginning, if you're not sure, go down the asthma guidelines, because that's a safer approach. Other people might want to add to that, but that would be my approach.
I think that's exactly what I would say.
Yeah, and it's reassuring to know that it can still seem messy in secondary care, and that's why we have the option of referring. Great. Next couple of questions that are kind of in a similar theme to each other are about, are there any adverse effects or unintended consequences of using more inhaled corticosteroids? So a couple of questions about specific concerns, like does it increase risk of diabetes or pneumonia? When do we need to worry about things like adrenal suppression or sort of steroid alert? I think, Dina, you touched on this, saying that at the low end of low dose MART is really not a concern at all. But yeah, it'd be great to cover that. Who'd like to take it?
Yeah, don't mind coming in a little bit on that. So the evidence is that people generally do not overdose themselves with things like air and MART regimes. The reason being, what they're actually doing is treating their asthma when they're giving themselves those extra doses of inhaled corticosteroids. So you don't tend to see the excessive use of inhalers in the way that you would do with a SABA inhaler, which isn't treating the inflammation at all. So that's one thing to sort of hopefully make you feel a little bit better about that. I think all the air studies, the average daily dose that people were taking was around 50 to 100 micrograms of budesonide daily. That's tiny doses of budesonide. And the MART studies say around 2 to 3 puffs a day. So you're not even getting up into the realms of medium dose ICS. So at that point, you are very unlikely to get any systemic side effects from the inhaled corticosteroids. It's only when you're getting up to the realms of high dose, you kind of maybe like 2,000 micrograms of beclomethasone equivalent, that you're even going to start getting those kind of risks of adrenal suppression, etc., where you would be thinking about introducing a steroid warning card. But we just don't see that generally tend to happen with the air and MART regimes. Have you got anything else to add, LJ, to that?
No, I really don't worry about it. It's not something we see. We only really get worried about systemic absorption in people who I see who are on like super high dose of ICS. So on the kind of lower step down on all our diagrams, we really don't see it. So I really wouldn't worry. I'm always encouraging my patients to use more of their inhalers rather than less, because what we're aiming for is control of disease, because that's best. And the worst thing is if they end up having to have oral pred, because that's like a huge, massive dose that is much more likely to have side effects than any of the puffs that they're taking on their inhaler. So I think we need to be really clear about that message.
I think the only other thing I would add to that is just to remember that it is just the lower dose inhalers that tend to have the MART or air licenses. So just be aware that the higher dose products aren't licensed for air and MART, because there is the risk of ridiculously high doses of inhaled corticosteroids with those, but not so much with the lower dose.
Okay, thank you. And just looking through the questions, another one focuses on how do we improve when a lot of our asthma reviews might be done by phone or using accurate questionnaires at the moment? I guess sort of recognizing the current context of general practice at the moment of a system that is struggling. So where to begin really, and how do we try and improve? So maybe Artie or Vina, do you want to come in on that with a general practice perspective?
Yeah, I'm happy to give an answer. Maybe others can fill in as well. I think you're right, and that ideally everyone would have an asthma annual review, but it may be hard to achieve that. What I've seen a lot of practices do is do the ACT score, and for anyone with an ACT score that's lower than about 20 or 21, to prioritise them. I would also suggest that using these searches is a good way of prioritising patients and looking at the ones who are, not using their inhaled steroid, who are, have had exacerbations, who've had doses of oral steroids, who've used more than 3 or 6 salbutamol per year. They would be the ones ones to really focus on. So I think if you're going to stratify them, what we did was actually try and start with the ones who are the highest SABA overusers. So there were someone like 20. So we got them in first, and then we kind of went down the list. And I would also say that, you know, realistically, not everybody is going to be able to be controlled in this way. Like, we try that, but we had a lot of patients who had really severe asthma and COPD, who also had bronchiectasis, who also had ABPA. You know, some of them have multiple diagnoses, some of them have got cancer as well. So, you know, it's not everybody we could get in. So don't beat yourself up if you can't get everyone perfectly controlled on this method, because it is hard, and you have to appreciate people's physical and psychological situations, but just do what you can. And if you're going to start anywhere, start with the I would say the easy wins, which are the ones who are using a lot of salbutamol but can be controlled on some of these regimes. So stratifying it in that way, I think, is probably a realistic way of looking at it.
Yeah, I mean, I agree with what Vina's saying, but I would strongly encourage everyone to try and have processes in their practice so that patients with asthma are reviewed face to face, because I think if we're not seeing people face to face, then we're not really able to have proper conversations with them about their control. We're not really talking to them about their inhaler technique, and these are absolutely crucial things to be doing. So just sending them an ACT score, which is looking at the last 4 weeks of control. I mean, one of the examples that I sometimes give, and Vina talked about her case, one of the cases I often talk about is a patient who was always reviewed in her birthday month in the summer when her asthma symptoms were in the winter. And so her ACT score was always brilliant, but actually she was really severely exacerbating in the winter. And if you looked at her objective inhaler use, then she was on very few ICS and a lot of SABA. So she was at high risk. So we do need to look at all of the factors, and we really should be offering, you know, the quality measure is to offer people a face-to-face review annually. I know some practices have moved to telephone and ACT florries, but that's only giving you one bit of the picture that you need. And if we're really going to improve asthma control, which we absolutely have to, because asthma control is poor, we are going to need to see most of our patient face-to-face. But completely agree with Vina, let's stratify and let's look at the highest risk patients first.
No, I do agree with you, and I don't want you to think that I'm suggesting that is a great way of managing it by just picking some patients. But I'm saying if you're going to try and prioritize some urgent ones to see first, then that's what I suggest. But yeah, seeing everybody face to face, I would agree with as well.
Yeah, I think everyone also is agreeing in the chat. So I think we do have to. So we absolutely have to improve care. We also absolutely have to be pragmatic and understanding of the situation. What I would say is this is a whole system approach. So this isn't just left to primary care. This is a shift that's happening in primary, secondary, community, A&E. You know, we are looking at how we improve asthma care across the entire pathway. So everything you do, every patient that you can see and can optimize is a contribution to the overall improvement in population health management, which we're all completely invested in. So even if it feels like, you know, at the moment, you know, if you look and you say in this quarter, we can only, you know, see that our absolute top like 5%, that's actually massive, because then we can all chip away and we will really have a huge impact. I really think these guidelines and this approach has the potential to be completely transformative in a way that we've not seen at all in asthma care in my entire life. So, you know, it might be overstaying it, but like I really, really think this is a massive opportunity, and being part of it is really fantastic.
That feels like a very inspiring note to end the evening on. I'm just going to flash up briefly a slide where you can do a QR code to feedback about tonight's webinar. But I just wanted to thank everyone again for your attendance this evening, for being so engaged and interested, and I hope you bring that enthusiasm and the expertise and knowledge and experience from our amazing speakers. Thank you so much, RC, Deborah, Vina, and LJ. I hope you bring that into your practice tomorrow and into the future. And do remember the Greener Practice website has a wealth of resources that we've mentioned tonight, including the visual guide to asthma reviews, the high quality low carbon asthma care toolkit, which will soon have some extra updates in light of the new guidelines, along with the respiratory special interest group